together. So we met
Yeah,
a while ago for the first time,
Oh,
and
wow. Since the Montessori days, huh?
and then now
that's
our
right.
kids are in the same school and they're in the same class too. So we've known each other for a while.
Yeah, it's
So
been what, like 3, 4 years now. Yeah.
yeah, and you're gonna be our first guest on this Two Docs
Awesome.
One
Well,
Mic
thanks so much for
podcast.
having me.
Yeah, yeah, it's
It's an honor
awesome.
to be here. Yeah.
Yeah, it's great to have it's so far people have just been whoever is listening out there, has been listening to just the two of us talk and give our views. But we're limited. I mean, I'm a cardiologist. He's an orthopedic surgeon, so we know about our fields and what we do, and the perspectives we have. But it's always good to have other doctors come on, and you're our first guest. Hopefully, we'll have more guests in the future. But
Yeah,
it's
my brain is totally maxed out. I have nothing else to contribute, so I'm glad to have
that's what they say about
glad to have
Botox.
you on,
Just
Janik.
bones. Just think of bones.
Oh,
That's
good.
all you gotta think of.
Yeah, yeah, dude. Bone broke, me fix, and we've already talked about that. So,
Well, we work with orthopedic surgeons too. So
right, right. But let's just talk about that, Janik. Tell us a little bit about your background. I think that'll be interesting. As a plastic surgeon, and there's so many different ways that plastic surgeons can take their craft. But how did it start with just how you got to where you are? What was your path,
sure.
in
So
school and training?
yeah. So my path was a little more convoluted than I would say most people. Um, and so there's kind of two tracks of going into plastic surgery. The more traditional track this day and age is doing the what's called the integrated route, which is when you go to, it's 4 years of undergrad, 4 years of medical school, and then you can match into a 6-year straight plastics integrated program. And that's what a majority of kind of trainees are doing now. Historically, it's been what's called the kind of the now it's called the traditional tract, or and so that would you would do general surgery for 5 years, and then you would do plastics. It used to be 2 years of plastics, but then they changed it to be 3 years of plastic surgery fellowship, to match the integrated track when they started doing that. And
Gotcha,
so
gotcha.
when I did general surgery, and when I was in training, I never really had any exposure to plastic surgery, which is not that uncommon. Times, you don't get that rotation, or you just don't get exposure to it. And that's true for a lot of, I think, medical specialties. Even in medical school, I had no exposure to plastic surgery, so really didn't know anything about the field. And when I was finishing general surgery, it kind of came time to make the decision if I want to be, specialize in something. I really didn't have any draw to plastic surgery because I didn't know anything about it. And so, a good friend of mine, actually, we were kind of in the same boat, and he chose to do plastic surgery because he didn't like anything else in general surgery, but I wasn't bold enough to make that kind of choice. And so I ended up doing kind of transplant hepatobiliary. So I actually did a transplant fellowship in liver, kidney, and pancreas transplant, and then I did a
Wow.
second fellowship in hepatobiliary surgery. And
How long was
so
that after general surgery?
2 years. So
Okay.
I did a year of transplant, and a year of hepatobiliary. And so after that, I took a job. I was up in kind of outside of Detroit in Michigan, doing a combination of general surgery and hepatobiliary surgery. And so I did that for, close to 7 years, 6.5, 7 years, before
Wow,
kind
that's a
of,
long time before
yeah,
you
before
decided to
I
switch
decided to
gears.
come back. Yep.
Oh man, how did you
Um,
like that? Doing the transplant surgery and stuff.
so, in my practice, I never did transplant. I ended up just doing more hepatobiliary and
Okay.
general surgery. And so I did a lot of abdominal wall reconstruction, which is kind of dovetails into plastics a little bit.
Right, right.
Historically, it's been kind of plastic surgery, but more recently, it's been taken over by general surgeons. And I really enjoyed that. I really liked the patients, really had good outcomes, and they were really thankful and happy. And hepatobiliary is great, but you're dealing mostly with cancers, and mostly a lot of not so great cancers, and
Right,
survival,
right.
even with the best surgery, is not amazing. So, um, and I actually have the fortune of having two really good friends of mine who are both plastic surgeons. And so, literally, it's like you would talk to your friends on your drive home. Hey, what'd you do today? And like, as you talk to them more, like, oh, that
Yeah.
sounds pretty interesting. That sounds kind of fun. So,
Right.
so that's what kind of started kind of my thought process and wanting to do it. And so 2 years into practice, I actually started 2 to 3 years into practice. I kind of entertained the idea. But then I shut it down I was like, this is crazy to go back to training,
Yeah.
especially 3 years of fellowship, because, and so I kind of backtabled it. But then it kind of kept coming up, of like, well, this is still an interest, or this is something that I kind of want to do. And it got to the point where in 2018, it was like, well, if I don't do it now, I'm not going to do it, right? Because, my first one was still an infant. I still had a lot of years left in my career, and so it just kind of made sense. And so it was one of those, if I don't do it, I'm going to regret it. And so I applied and fortunately
I mean,
matched. And
that's admirable, man. Just to pull the trigger and make that decision. I mean, that's a huge practice and lifestyle change to go
Yes.
back
yeah,
to training.
Especially when you have kids, right? I mean, that's so much harder. Like when you're single or not married, it's much easier to kind of make that change. Even then it's tough, but
hmm
especially when you have kids and you've been in your career for a while, you've already trained for so long, making career change. Well, when it's a calling, right? It keeps calling you. It keeps kind of in the back of your head. You keep thinking about it. That's something you have to pursue, right? That's a big lesson in life too. That the one thing you don't want is regret.
I 100%. That's kind of how I live my life. You don't want to have any regrets. If I applied and didn't match, and I would be doing general surgery today, and it would be fine, and I would be like, at least I can say, hey, I tried.
Yeah, you went
Um,
for it. Yeah, yeah.
and then but like, yeah, but I'm super happy. I'm so glad it all worked out and
Yeah.
I matched,
So, dude,
and the
how
process
was
was amazing.
how was the application process and interviews and stuff? I mean,
Yeah,
you were
it's
probably more experienced than maybe some of the
very.
attendings interviewing you. Just
So it was actually kind of interesting. Um, you know, there's some programs. So okay, so I ended up getting interviews at pretty high level programs, right?
yeah,
But then some programs in that same category didn't even give me an interview, right? And then I think it's because, and when I was going to these interviews, their question always was, well, how are you going to be trainable? You've already been attending. Like, how are you going to take direction again and like
right.
be a resident, right? And so I think some programs, at least that I interviewed at, they were intrigued enough to at least bring you in and see what you had to say. And other programs, right now, this guy is not going to be trainable. And so I think I had that dichotomy in my application. But I think when I talk to people and I tell them like, yeah, I'm committed to doing this. I mean, you know,
Yeah,
um,
yeah.
So let me
that's made
ask
the
you this:
difference.
when you
Yeah,
went in and got in, were you trainable? What were the struggles like in the beginning? Like,
you know,
going back from doing being an attending, doing hepatobiliary surgery, and now going into plastics fellowship. Were you trainable? Like, how did you take that initial shock to your finances and your ego?
yeah. So I mean, the ego was not an issue for me. Partly because I had already decided, right? I had decided I was going to commit to doing this, and so I knew what was at stake or what was required to do it, right? The two issue the financial part was the hardest, right? And it's not like my lifestyle was that exaggerated, but I mean it's still a big difference, right?
Massive difference. Yeah, yeah.
Massive, yeah. I mean, so we went from living in a house to living in an apartment. I mean, this all happened during COVID. It was like not the easiest thing.
Man,
And
that's a lot
so
to juggle at one time, dude. An
yeah, and
infant,
then and
COVID
and
is
the, you know,
happening. Yeah.
and then my wife was pregnant with our second. So literally, like,
Wow.
5 months into fellowship, or residency, we had our second child. So um, that was part of the hardest part. And then also not owning your time, as you guys know. And the best part about being an attending, I think, is that you control your own time, more than anything else. And obviously, when you're a resident, you're on someone else's time.
Right, right.
So those are the challenges, more than the
Did,
learning. And then
Yeah. Did people
plastics is
treat
so
did
different.
people like just did people treat you differently when you started? Like, since you had been attending, were attendings are a little bit more lax with you or give you more freedom compared to other residents that were much younger?
Not particularly. One, so the place I trained at, we were all the same. We were all general surgery trained, and so they were used to having people who are kind of fully trained, if you will, right? But plastics is very different. I think people, and other specialties don't necessarily understand, like, how they handle tissue and all their principles are so different than general surgery. It's almost like learning all over again, you know. And then you have like hand surgery, which is like completely like different. Like there's, you're like a medical student trying to learn that again, because you have no exposure to it in my training, right?
Yeah,
Obviously,
no,
ortho is
for
different,
sure.
but so there were some challenges like that. I mean, I think the first 6 months you just felt like an idiot. You went from like knowing everything to knowing nothing. And so the first 6 months, I mean, I literally had to like study hard, right, to try to just kind of catch up, if you will.
And that's a very good point because like, it's people who aren't familiar, like they think surgery is just all surgery is surgery, but it is so different. Like
Hmm.
orthopedics, which is what I do, but I do hand surgery, right? So even within ortho versus hand is like they're completely different fields, even though the bones are involved, right? And same with what you're saying, the tissue handling, the ability to raise a flap, and all that stuff. I mean, that is very specific and very different compared to standard general surgery training, which is what your background was. So it's a
Yeah,
complete gear shift.
yeah. It's always, the kind of the running joke is, you have when you have, you're trying to, you have general surgery hands, when you walk and you start and you want to, leave with plastics hands, right? Because,
Right,
and it's
right.
very true how general surgeons handle tissue, and it's just from our training, right? I mean, because the general surgery training is more trauma based, and so
Yeah.
obviously, if you're trying to save someone's life, you're not really worried about, am I pulling too hard on this tissue or whatever, right? Like, yeah, is the incision a little crooked? No, you're not care. You don't care. This person's dying, right? So,
Right, right.
um, the situation is different. But then I think that training or that mantra then, proliferates all your training sometimes. So
Yeah, let me ask you this. How did your wife take it in terms of just family dynamics, right? Like it's a big, almost, I wouldn't want to say a step backwards, but it's a change, right? Financially, lifestyle wise and stuff. It probably took a huge amount of support from her too to
oh
make the
yeah, for
decision,
sure.
I'm sure.
Yeah, no, absolutely. Yeah, no, she was supportive all the way, and yeah, I mean, couldn't have happened without that
Yeah.
support. So
No, that's huge.
yeah,
That's really cool. I mean, very, very non-traditional path, which I think is awesome.
very yeah,
But that gives you that edge, right? I mean, that you have a different perspective on plastic surgery, and those skills as well to kind of, adapt as well, be flexible when you come and do surgery. So I know now you've done the training, and now you're working and you have a plastics practice, and you're doing all kinds of stuff. So I know, tell us a little bit about the types of things you're doing, because I know you're doing two different types of plastic surgery. You're doing the one that we see in the movies, and nip tuck or whatever, the cosmetic side of plastic surgery. But then you're also doing a lot of insurance based, like trauma related, or burns, or reconstruction stuff as well. So tell us a
right.
little more about that.
Yeah, so yeah, exactly. My practice is, half reconstruction and half kind of aesthetics or cosmetic surgery. Very different on the reconstructive side. Probably the two most common things we do are kind of hand surgery, mostly hand trauma, or infection, and then breast reconstruction or breast cancer. So those are the most common. But I think reconstruction, kind of runs the gamut. We work with orthopedic surgeons to do some reconstruction. We work with neurosurgeons to do reconstruction. So, wherever there's any soft tissue loss, or there's critical structures like bone or hardware that need to be covered as a result of that soft tissue loss, that's kind of where we come in. So, I do like that part of plastic surgery. You interface with a lot of different specialties. You're not siloed like a lot of other specialties are, um, and so it's nice. You have a lot of colleagues, and you learn from their perspective too, because kind of like what Adil was saying, every surgery is so different. And so, what I worry about when I'm covering something and what the orthopedic surgeon is worried about, I think you have to consider both those things to get the best possible outcome, right?
Yeah, I
And
mean, I
so,
would say like for me, the surgical service I work with the most by far is plastics. I do a lot of combined cases, like a lot of brachial plexus cases, big soft tissue defects, post-traumatic wounds, and
mhm,
things like that. I operate with the plastics guys a lot, and those are actually really fun cases. Planning them and like you're saying, hearing the different perspectives. Like I'm thinking very much bone and joint recon, and then functionality versus aesthetics, how the tissue is going to look, the different types of tissue that will move, will not move. It's very fascinating. I love doing those cases combined.
yeah, yeah. So I enjoy that. I mean, in general surgery, you don't, again, same thing. You're a little bit more siloed and into
Yeah.
your own field, right? But here we interface with everybody, which is really
And
nice.
so, what percentage would you say of your practice is that it is, kind of cosmetic plastic surgery stuff, and how much of it is reconstruction, and how much of your practice is completely cash based, and how much of it is you're going through insurances? What percentage would you say is?
Yeah, so my I do my reconstruction at the county, and so there it's kind of you're salaried, and they you're dealing with a lot of uninsured or underinsured patients. And so there you're salaried and you whatever you just do what you do, and that's kind of it, right? I would say that's probably like, initially it was more 50-50. Now it's probably, I'm probably there like do, 40% versus 60% doing aesthetics. So yeah, so 60% of my practice is probably cash pay, and about 40% is um, kind of insurance based.
Now I'm curious, right? I mean, this is we Adil and I both practice. He works at Baylor, and I have a private practice, and most of our stuff that we both see is insurance based. We do not do much cash based
Hmm.
consults or treatments. Yeah, some patients who don't have insurance need to pay cash, mainly to get clearance for plastic surgery that they're paying completely cash for. But
That's what
you
they're
know,
saving. That's what their HSA is going to.
of course, like that's it's sometimes it's frustrating. Like the patients come in and they're getting a BBL or a nose lift or nose job, and then I'm like, okay, I think we need to do an echo because of your risk factors, and they're like, oh, I don't know if that's too much money for echo, and I'm like, really? Yeah.
Yeah, I
So how
mean,
is that dealing with, like, uh, what kind of patient dynamic is that? Is it more of a transactional relationship with a patient when someone is coming in paying you cash to do a job, versus in your job at county where you're really doing patients uh, a service. I'm just trying to see, where is there more transactional relationship in that case when someone's directly paying you to do something for them? How is that dynamic?
so for me, the dynamic is, honestly very similar, because the patients in the aesthetic world are coming in because they aren't happy with something, right? Some part of their body or appearance or whatnot. And so it's my job really to educate them on, well, what are your options, what and kind of what does that all entail, and what are the risks associated with that, and kind of what's the downtime and what's the cost, and how are you going to put all this together to decide what's the best treatment for you at this point in time, right? So it's not dissimilar to kind of what we would do, like when I see a breast reconstruction patient in clinic. It's the same discussion. Okay, well, these are your breast reconstruction options. These are the pros and cons of each option, and then kind of go from there. I think in the aesthetic space, obviously, you know, um, the kind of the expectation of service is higher, right? So you have to be more available to your patients. So I think that's an issue. I think there are some, you do have to be careful. It's a very slippery slope, like you kind of were alluding to, that if someone's paying you, you kind of may do something that you may, I mean, I wouldn't say it's wrong, but like you may kind of push the boundary a little bit, right? Like for example, if I see a patient and and I feel like I can't really help them, I'm going to tell them like, well, I can't help you. You can, either your aesthetic problem is either too complicated for me, or your aesthetic problem is not significant enough for me to make an actual difference. But on those patients, it's very easy for me to also say, hey, I'll just operate on you because you're paying me cash, right? So that's kind of an individual surgeon, decision. You know, I can't sleep at night if I'm going to tell someone that I can do something that's going to make them, that's going to help them, then I can't do it, right? The other big difference in aesthetic surgery is patient expectation, right? You got to set the expectation. That is like the entire thing. And you have to make sure the patient is on the same page as you are. Sometimes that's a challenge to figure that out, or to get that. And sometimes you think you're on the same page, and then only after surgery you realize, well, maybe we weren't on the same page, right? And so if you want to have happy patients in the aesthetic surgery, that's really, you have to understand kind of what they want. You have to make sure you're on the same page. And then you have to make sure they trust you to get them through any issues that you're going to come up with. And
Man,
so,
that's it's interesting. Like, I don't do any aesthetics or cosmetics in orthopedics, but even in our stuff, I mean, setting those expectations is so important. And I think it's honestly like one of the most challenging parts of the clinical encounter with the patient is discussing and laying out the expectations is just so that patients know what the whole journey is going to be like, up to surgery, through surgery, and the recovery afterwards. And so often, man, I think like, oh man, I think I've done a good job. Like this patient gets it. I'll like draw on the little sheet on the exam table what it's going to look like, give them these post-op protocols, everything. They're like, but why am I still stiff? I'm like, dude, it's been like 3 weeks. Like, come on, you said an elbow replacement. Of course you're going to be
Yeah.
stiff. But it's just like, what we say, we give them so much info, right, in a short amount of time, and what they grasp is sometimes very different. I can only imagine. I can't even imagine in the aesthetic world where so much of it is perception. It's not like objective. How patients could really easily misconstrue, or they think they're coming in, they're going to come out looking like one thing, and I can only imagine how difficult that is.
Yeah. Well,
It,
the
it,
other dynamic I want to kind of add on to that is, there are some patients that are maybe one-off patients that they do, one-off aesthetic procedure because they're not happy with the certain part of the body, the nose, the eyelids, the lower cheek. But some patients, they get some kind of aesthetic procedure or plastic surgery procedure every other year, and they have these things whether they're never satisfied or never happy, right? And it is very important to recognize as patient early on as well. Hey, is this the patient that has
Mhm.
already gone through so many procedures and they're still not happy with that? How is that dynamic also that comes into play where you're setting expectations, but you know that this patient may never be satisfied?
Yeah, and so again, actually a great point. I think again, individual surgeon. That's where kind of sometimes surgeons' egos come into play. Like I think like if I see a patient that's had 3 operations and they're not happy, like I don't think I'm gonna make them happy, right? And I would tell them that. Like I think that you know what you're looking for, I can't deliver. And I've told people that. I've had people who come with very minor kind of what they, I mean, for them it's not minor, I'm not downplaying it, but I mean when you look at it, when I look at it, I don't see that as a big difference. And so I'm like, well, if it looks minor to me, it's really hard for me to improve that, right, to any meaningful extent. And so yeah, I think again, you have to be honest, and that's where it comes in, where like, okay, we're still clinicians, we're still physicians. Yes, there's money involved, but that's when you have to have your kind of your own ethics and your own kind of morals to like what you're going to do, right? Because and again, that patient that you just mentioned, they will find someone to operate on them a fourth or fifth time. They will
For
find that
sure.
person, right? And the other thing is you have to realize, like, I mean, do you want to deal with that headache, right? Because they're going to not be happy. They're going to want a revision for free, like all the baggage that comes with that. I mean, you kind of you got to
So
decide at
that
the
that's
end.
an interesting thing you just mentioned. Let's say you have an honest discussion, whatever. You and the patient are on the same page. They have a blepharoplasty or a rhinoplasty or something, and then afterwards they're just not happy with it. They're like, "Oh, I
Yeah.
thought it was going to be blank. I hate it. Whatever." Is that a common thing in the aesthetics world to do like a redo or revision surgery free of charge if a patient's unsatisfied?
Yeah, so I would say in my practice, if I think what they're unsatisfied with is reasonable, right? If I think it's reasonable or if I think I can improve it, I will at least waive my fee for the revision. Obviously, they have to pay
Okay.
for anesthesia, facility, that sort of thing, right? But um, if I feel you know, like I did exactly what we talked about doing, and that's the best, outcome that you're going to get from that, then no, I wouldn't offer them a revision just to have that, right? It's like
Yeah,
like
yeah.
a common example I have for that is like, let's say you have a patient who has a little bit higher BMI and you do liposuction on, right? And if they're not, I mean, and you made a meaningful change, right?
Yeah.
But they're not happy because they still just have a lot of adiposity left. Well, I mean, I'm not going to do a revision.
Yeah.
You just because they just want to redo like more stuff taken out, right?
Yeah, yeah,
So
yeah.
I think so that's kind of how I deal with those things.
Gotcha.
Um,
Is that a part of your discussion and training throughout your plastic surgery training of where the limit is, right? I mean, where how do you put those self check-ins or stops in your practice? Because it's very easy for an aesthetic practice, a cash-based practice, to just keep going and keep pushing the boundary. And human nature internally is something that can get attracted to money really easily, right?
yeah. Yeah.
How is that built into your training, or where to put that full stop? Because, for example, for me, like, or Adil, like, we have insurance sometimes, stopping things that we could do. Like, I mean, we have our ethics as well, and we have our morals, and we wouldn't want to do the same procedure, same echo every month, or stress test every 6 months for a patient, because we
Right.
know there could be harmful effects of that. But insurance also comes in and puts a stop to it. But is that a discussion you guys commonly have in within your training of where to stop and when not to do something?
Yeah. So, and I think,
Insurance is our undesired hall monitor. That's what insurance ends up being.
well, I can tell you about, yeah, I mean, I can tell you, I can talk about insurance based stuff too, in terms of like ethics
Yeah.
and that sort of thing. But just from my general surgery days, but like, you know, in our, from a training standpoint, you get trained for a couple things, right? You get trained to kind of recognize what's called body dysmorphic disorder, right? Those are the patients, like you said, that are never satisfied. You kind of want like stuff done. Like usually it's like minor things that are a big deal to them, that, to try to identify those patients. So that's one. We do talk about kind of the kind of ethical approaches to like cosmetic surgery. If someone, again, it's also like, okay, another example is, let's say you have a woman that comes in and she wants breast implants that are just way out of proportion to her body, right? And so again, she'll find someone who'll do that, but that's your work walking around too, right? If it looks ridiculous, then I mean, yes, she may be happy with that, and that's what she wants. But again, do you want that patient to kind of be advertising you that way, right?
Yeah, it's your
So,
reputation. Yeah.
and so if you look at plastic surgeons, I mean, there are certain personalities that will attract certain types of patients, and it kind of just shapes your practice that way, right? Because if you do one of those patients, you'll get more of those patients, right? Because again, that's your look and that's what you do, right? Those are some of the nuances in kind of the aesthetic world.
And then
Um,
one question, Janik, about like training in particular. From my understanding, like again, working with plastic surgery residents throughout my residency and now as an attending, a lot of training is more so biased towards the recon side, correct? Like the
Correct.
pure aesthetic, cosmetic side. That's almost you have to seek out a subsequent fellowship afterwards, more in the pure aesthetic space. Isn't that true?
That's generally true. I train at Methodist, and we had a very robust. Our attendings had a very robust aesthetics practice, and that was
Okay,
one reason I picked that program. That they had a good combination of aesthetics plus reconstruction.
gotcha, gotcha.
So I got a significant amount of aesthetics exposure in kind of my training, more so than most people would, I would say. But you're absolutely right. I think if you go to a very high-powered academic program, it's going to be mostly reconstruction. Having said that, everything we do in aesthetic surgery is based in reconstruction. So it's the same techniques, just applied differently,
Right, right. I
right?
gotcha.
And so even when so I think sometimes, in the media, and not the media, but just like, online social media and stuff, people kind of say, oh, this guy, I'm a cosmetic surgeon and that person's a reconstructive surgeon. They can't do cosmetics. Like, that's not really true, right? They have all the training, and technically they can do all those operations.
Right, right. That's
So
another thing, like this whole like field of cosmetic surgeons, right? Because a lot of people like with billboards that advertise as a cosmetic surgeon, they're not actually plastic surgeons, right? A lot of them never did a formal plastic surgery training. Is that true? Like that's what I've heard as
that
well. That
that's that is correct. Yeah, it's
yeah.
somewhat misleading. So there's they basically created a what's called a board of cosmetic surgery, which is not really a board because it's not recognized by the American Board of Medical Specialties. So
Okay.
it's not a true board, but they
They
created this board
created
of
their own
cosmetics,
club.
right? Basically, and then they created their own fellowship. So they do, it's a 1 year fellowship. So basically, after you do any surgical specialty, so after you do either OBGYN, general surgery, orthopedics, neurosurgery, any surgical specialty, you can do a 1 year training in cosmetic surgery and call yourself a cosmetic surgeon.
Oh my gosh, I'm about to be a cosmetic bone surgeon.
Yeah.
Sign
And
me up.
so, and so that's what, and then, it's to the point, it's now so pervasive that like board certified plastic surgeons are just getting the cosmetic surgery board as well.
Really?
Yeah, because like that way they can say I'm like whatever board in cosmetic surgery, even though it's,
Oh,
you know,
okay.
complete invalid, if you will, right? So, but because of just a perception out there, you
So,
know.
what are
I
some
hear you.
procedures? How would you differentiate a plastics? Like, what, I'm guessing the cosmetic surgery fellowship has a limited amount of procedures that they're focused on, whereas the plastic surgeon has a much more wide array of things they could do. So, what are some things that a plastic surgeon is better trained to do versus that cosmetic surgery fellowship? What are some types of procedures that you can differentiate with?
Well, I think there's a variety of cosmetic surgery kind of fellowships, right? Some are a little bit heavier in face and some are heavier in breast and body. I think all the plastic surgery based cosmetic surgery fellowships are probably, I would say, more well rounded to kind of give you exposure to face, breast, and body. Um, you know, facial plastics, there's, ENT has a route to do facial plastic surgery. And so they'll do ENT and then do a facial plastic surgery fellowship. And that's all just face, facelift, brow lift, left, all that sort of stuff. The oculoplastics guys have, or I should say ophthalmology has oculoplastics. So they do all the it's like aesthetic surgery of the eyelids and the brow and all that. So, there's a lot of overlap. Um,
But,
I think I
for
would say
example, like
I feel like
orthopedics,
a
right?
lot,
Yeah.
yeah, a lot of the guys who are doing the cosmetic surgery fellowship, if you're general surgery or orthopedics, you're usually doing body work because I think the body work is a little bit more straightforward. The face is more complicated.
It's less forgiving.
It's less forgiving.
So, do plastic surgeons are when people are seeking out plastic surgeons, and they want to get a cosmetic procedure done? Are there certain plastic surgeons that are they market themselves as mainly focused on the face versus some on the abdomen or the hips or the breast? Just like in orthopedics, I mean, there's hand surgeons and people who do hip replacements or people who do shoulders. Is that the same kind of thing in plastic surgery as well?
It is. I think especially in larger markets, people kind of develop a niche so that they can actually stand out. Because if you say you do everything, well, everyone else does everything too. So what makes you better than everybody else? But then if you say, hey, I just do, you know, breast, then oh, you're like the breast expert, right? So that's kind of how people try to stand out. Sometimes it's driven by your own. I mean, part of it's driven by your own kind of what you like to do, right? And I think part of it's driven by kind of what type of patients you're seeing and what you're doing a lot of. Like, for example, like for whatever reason, let's say if I start seeing a lot of facelift patients, well, my practice is going to kind of gravitate towards doing that. And now I'm going to get known for doing that because you do one facelift that's good and it's good. You're going to get another one. What I mean? It just kind of stacks, right?
Yeah, yeah.
And so the practice kind of makes itself, if you will, as long as you like doing facelifts. But if you say I'm not doing those, then you know.
Dude, that's so true because like sometimes it's like the procedures that you really don't want to do. You do a couple of them and you become known as like the guy in town that'll do it. Like for example, like I do a surgery, a scapulothoracic fusion, where you're fusing the scapula, the shoulder blade, to the ribs on the thorax for like very bad post-tumor reconstruction or scapulothoracic instability. That case sucks. It's like really hard. It takes a long time. It's very high risk. But like no one else adheses. Dude, I get referred way more than I ever wanted to do.
Yeah, people coming in from out of town to see you. Yeah.
I know, man, but I could totally. When you just said that, that's what it made me think of. I was like, oh my god, I just saw a patient in clinic today who has had like a non-union of the prior scapulothoracic fusion that someone else did. And I was like, oh my god, I have to revise this. It's gonna be
A
horrible.
redo. Yeah. Even
But like
worse.
that happens for sure. It's like you start getting this cycle of patients, and like you never even intended it. It just happens. That's your practice just grows like that.
Yeah. Well, and
You
then
know,
and then like everything else in surgery, right? You do more volume, so you get better at it, so your outcomes get
Yeah.
better, and so like
Right.
it
Right.
just
Right.
feeds into itself, right? I
Yeah.
mean, can't stop the train after a while.
Yeah. All aboard.
so one thing I really wanted to get into in this discussion was, we've talked about the rise of the wellness medicine or longevity medicine and all these new trends that have come up. And we've done episodes on GLP-1s, we've done episodes on peptides. What kind of effect do GLP-1s are having on your practice in plastic surgery? There's a lot of patients that are losing a lot of weight. So maybe the demand for some of the the procedures for this the loose skin or the
Mhm.
liposuction probably are changing, right? The demands are changing, and maybe even there's more demand for it now.
Yeah, so the demand, yeah, I mean, agreed. So the demand is changing. I think it's changing with the demographic shift. Younger patients are seeking procedures, especially because of the GLP-1s. They've lost weight. So a couple of things, just kind of going from top to bottom. You see a lot of people who have a lot of volume loss in their face, so they look hollowed. They look aged. So if you once you lose volume in your face, you age pretty fast,
Those Zempic
right? So
face.
yeah, exactly. And so you see a lot of that. And so that's one issue. Then the loose skin issue. So skin
No,
tightening.
no, just let's just kind of elaborate on that a little
Yeah.
bit. What are you guys doing for that? That's a big topic and a big discussion and big, a lot of people are discussing the Ozempic phase or the phase they get after weight loss where they're,
Uh-huh.
everything kind of sinks in. So tell us what kind of procedures are there around that people can seek out when they've lost that much weight?
Yeah. So, I mean, every case is kind of different, obviously, but in general, the concept is, we want to use fat grafting. So fat grafting is where you'll do liposuction on one part of the body to harvest or take the fat, and then we'll process it and inject it into the face to restore that volume you've lost. And so, and then in addition, if people have kind of loose skin, there are some things you can do for skin tightening. Now, some things you would do, you can do for skin tightening if you have kind of mild to moderate laxity. But if you have a lot of laxity, then you need to do surgery, which would be like a facelift, right? A facelift or a neck lift, where you're actually cutting out the extra skin. So from a facial rejuvenation standpoint, that's kind of what we do. On the body, again, like I said, there's you can, for some patients, you can do just some skin tightening procedures. Those involve usually some form or fashion of heating the skin and causing contraction of the collagen, to tighten the skin. And again, if you have a lot of loose skin, that's not going to work. And so you're talking about doing surgery. So the one thing I would say that's probably becoming more common or more popular after the GLPs is what's called a circumferential or 360 tummy tuck or abdominoplasty. So because they have kind of loose skin all the way around. And so whereas before you can address most of that just from the front, now you have to kind of go all the way around.
It's
Dude,
interesting.
it's funny you mentioned the circumferential one. I operate on the same day as one of the plastics guys, and he at least he does. I don't know if you're the same. He hates doing that because he has to do a position flip in the OR,
Oh yeah.
which like it lengthens the surgical day so much. I mean, he's like walking down the halls, cussing during the position flip. He's like, God, I hate doing this.
Yeah, the flipping, yeah, it just adds more time, you know. And then if you have any airway issues, it's like a pain in the butt to get
Man,
to,
I
right?
know
Yeah.
it.
As much as you can not prone them, it's good.
Yeah, no kidding, dude.
Yeah, I can imagine. I mean, it's an interesting space, an interesting time we're living in where now there's a lot of you talked about the board of cosmetic surgery, but then there's a lot of this trend of med spas that's rising, right? A lot of like every person I know, every other person I know is doing some kind of Botox, fillers, Sculptra, whatever types of different injectables or peptides for skin rejuvenation or improvement in the I guess anti-aging procedures. Uh, I want to see what your take on that is as a plastic surgeon, and how do you feel first? I mean, what should patients seek out, and where should they seek care? Are these med spas and someone who was just trained over a weekend or through a conference on these injectables appropriately trained to do these procedures, and kind of see from your
Yeah,
perspective.
like the
Yes.
online course from DeVry University is that is that adequate?
Yeah. So, yeah, I mean, this is obviously a hot topic, across our specialty and, just across aesthetics in general. I mean, aesthetics it's a large space. There's definitely a lot of specialty creep. And kind of, as you mentioned, a lot of people are doing it. So, I think from a patient standpoint, it's really kind of seeking out the person who's probably the best trained. And, there are great injectors and practitioners out there who, you know, maybe are a nurse or a nurse practitioner or even or primary care, whatever, some non-plastic surgery specialty, but they are well trained because they've done a lot of courses. They've done it for a long time, and so their results are good results. They're safe, they're ethical. But then on the flip side, there are people out there, yeah, they do a weekend course and are doing all this stuff, and their results are not that great, and they have more complications. And so, there's no policing the field in a way, right? Because, everyone can do this stuff, right? There's no regulation per se. And so the onus is really now on the patient to decide how are they going to find the provider that, they think is kind of the best and the safest for them. Fortunately, a lot of the injectables and stuff, have relatively low complication rates. Problem is, if you do have a filler complication, it can be devastating, right? Because you're talking about stroke, blindness, or tissue loss, and that's permanently disfiguring or permanently disabling, right? So, I mean, uh, I think because the frequency of it's so low, a lot of people get away with doing things they probably shouldn't be doing or not trained adequately to do. From my perspective, I think if I was a patient, um, I would want to go to someone who can handle the complication that may occur from what they're going to do, right? And I think, even like, cosmetic surgeons and other people, like that's not always true for them. Like if like if you're an orthopedic surgeon, you did a cosmetic surgery fellowship, right? And now you did a tummy tuck, and now the patient has to get admitted to the hospital. Like if you have admitting privileges for ortho, right? And you let's say they're not gonna let you take that patient to the operating room to wash out a hematoma because you don't have privileges to do that because you're credentialed in orthopedic surgery. So like you can't even take care of that patient and deal with your own complication, right? So I think again, those are little nuances that no one really talks about, patients don't really know about, but you know when it really happens, you're essentially abandoning the patient, right? And so I think that's how I would want, and I would want to pick someone who can at least handle all the consequences of what you're going to do to them.
Dude, totally. I mean, I had a patient that was referred to me for something like that. There's this lady, she was like in her 70s, and she went to a place like this. Like, I don't know if it was a med spa, it was some wellness type, holistically advertised place, and they injected paraffin wax
Oh,
in her
geez.
face and in her hands. Like she was an older lady, so her hands had some standard age-related atrophy in the hands. They become
Yeah.
gaunt. Your metacarpal bones stick out, and she, wanted to have her hands look younger, and so she had them inject in her face to fill up her cheeks and throughout her hands in the interosseous spaces. And oh my gosh, dude, her face was, I felt so bad for her. I sent her to a plastic surgeon for the face, and then, I went in and removed, I mean, the paraffin wax was just like chunks of wax in her hand. And it totally like killed her interosseous muscles. She had barely any finger motion. It was horrible. But that's just an example that like I've seen. It's like,
Yeah.
it's crazy that people in Houston, some random clinic was injecting paraffin wax in this lady's face in her hand. This is
Yeah.
absurd.
It's crazy that this stuff happens in America in 2026, right? Like I remember in my fellowship, right? So like, the last couple years, I saw a lady who had silicone injected into her buttock, right? And we've long known that you don't do that, like, right? Like it's been like decades we've known this for.
Right.
And I'm like, I said when I first met her, like, what country do you have this done? And she goes, Louisiana. I'm like, I just assumed that it was in another
That
country,
could
right?
that could be a different country.
you know and then it turns out she went to her friend had recommended someone who's doing this out of their garage, and I'm like, how do you think this is like a good thing, right?
But
Like,
like you got to have some amount
yeah,
of personal responsibility. I mean, if you're going to go to someone's garage and they're going to shoot you up with some random silicone in your butt, I mean, like,
or
come
shoot
on,
you with
dude.
anything. Geez,
Yeah,
like, I mean, yeah,
exactly. That's crazy.
yeah.
Yeah, but
So
how do you? I mean, there's a lot of patients I see. I do cardiac clearances for and a lot of patients are going to Mexico to get some stuff done as well,
yep.
and because it's much cheaper, or they're getting it done in, and those practices just say, oh, get the clearance from your cardiologist. So then I'm here trying to get they need exercise tolerance test, they need an echocardiogram, an EKG, and some labs. And then I'm here, and I kind of want to counsel the patient, hey, you're getting the surgery. Like, I know it's not my job to do that because I'm not doing the surgery, but as your physician, as a doctor who's seeing you, I do want to be able to kind of warn them or kind of you know uh, let them know, because a lot of these practices are complete cash pay profit driven practices that are providing these
Yep.
services, and a lot of them are sometimes not really really putting the right safeguards in place to know when to stop and what to inject, what not to inject. What are some things? A lot of them are mainly run by non-physicians as well, non-physicians or primary care physicians or someone who's
Mhm.
not highly trained to deal with the consequences, right? So I are some of the things that I hear, like this frequency of BBLs that are happening, or preventative Botox, or nonstop fillers, or people are going weekly and getting fillers. Sometimes I wonder, is this in this profit-driven space, how do I, as a physician who's taking care of these patients, counsel them and warn them? Because I don't even know much about these things, and who
Yeah.
can they talk to?
I mean, so I think medical tourism, living in Houston, we see a lot of it, right? We see all the complications. I see them at the county hospital. I saw them when I was training at Methodist. I mean, you see them, right? Probably a couple times a month. Um, and a lot of those complications are pretty devastating. They're permanently disfiguring. And so, yeah, it's a huge problem. I think I mean, I'm glad you're at least mentioning to them that you're concerned about that. I mean, I think I always tell people, like, look, you're going to go somewhere to get surgery and then you're going to leave that place and like you have no follow up. What happens if something happens to you? What are you going to do? Right. And so, but that's all you can do is tell them, because the desire to get it done, and there are a lot of people who desire aesthetic surgery, right? The limiting factor is the money. And so when you can get what you want for cheaper, that drive is so strong, you kind of reason just goes out the window, right? You just kind of tell yourself everything's going to be just fine. And they probably have some friend that had it done and everything was fine for them. And so they think, oh yeah, it's no problem, right? But they don't really think through the steps of like, well, what if? They don't plan for the what if. And then when the what if happens, it's devastating for them, both financially, because a lot of people don't have health insurance. So it's financially devastating as well as, physically devastating.
Yeah, I mean, when a patient is undergoing a surgery, they've already decided in their mind that they think it's going to help them. Like
Hmm.
that's why they're choosing to do it. So what you said is so spot on. I mean, they're not at all realistically thinking and preparing for the negative eventuality, like the complication, and like, okay, now what?
Right.
And they're not
Right.
guided by that, medical tourism hub in Mexico or Turkey, right? Because those places are just like they're technicians. I mean, they're like little factories. People show up, they get the procedure, and they peace out. Those places, by design, don't have any follow up. I mean, they cut, 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 and then on to the next.
Yeah. So let's get into a little bit more specifics of I keep hearing fillers. Like, what are fillers? What is that? Why are people getting it, and why everyone is doing it, from a nurse practitioner to a nurse to the primary care physicians? And most primary care physicians have completely switched their practice from being primary care to purely being a practice where they do fillers all day. So what
Yeah.
is it?
So
Why should people get
so
it? Why should people not get it? What should they watch out for?
so in general, when people talk about fillers, they're talking about what's called hyaluronic acid fillers. So hyaluronic acid is a natural component in your body, in your tissue, and it basically provides volume to your tissues. And so what they do with the hyaluronic acid fillers, because you're in your body, hyaluronic acid turns over every 24 hours. So what you do is they cross-link it, which means they chemically bond it in a certain way to affect the stiffness of the filler. So you can think about it as kind of a soft to all the way to a stiff filler, because you're going to use those in different parts of the body. So if you're going to, you know, inject into the lips, you're going to use a softer filler. If you're going to inject it into your mid face, you're going to use a stiffer filler because you're trying to lift the tissue. The more cross-linked the filler, it'll also last longer. So, for example, filler in the mid face could last 12 to 18 months. Filler in the lips will last 6 months. Okay, um, and kind of the why you do it is because you're trying to volume restore or volume enhance, right? So, like I said, one of the first signs of aging is volume loss in the face. And so by restoring that volume, you can kind of create a youthful appearance. It's kind of now going a little bit more out of style, but before, the big lips were, really popular, and so that's volume enhancement. It's like taking someone has normal kind of size lips and you're adding more volume because you want them to be bigger. So it's a tool for kind of volume enhancement, if you will, right? Um, and so, you know, There are other kinds of fillers, but that's kind of the most kind of common. There are other fillers that will actually stimulate collagen, and
What
you
are
know
some of those?
so Sculptra is a collagen stimulator, and so typically that requires you to do a series of them, and then so basically, so with the hyaluronic acid filler, as soon as you inject it, you see the result, you see the volume enhancement. With Sculptra, you inject it, you initially see it because you actually put in Sculptra mixed with saline, right? So you see the volume, but then it goes away and you basically kind of almost look like you didn't do anything. And then after you finish a series, you actually see the volume changes because you've actually built up new collagen. So, and then that's kind of permanent, right? Once you build that new collagen, that lasts for a much longer time.
So
Um,
when patients are going to a lot of these aesthetic practices to get Sculptra done or to get fillers done, what are some things they should watch out for? What are some complications that could happen? And could anyone be trained to do that pretty easily?
so I think you know aesthetics is an art form, right? So like you kind of do have to develop and have an artistic eye for what you're doing, and that is grounded on knowing the underlying anatomy, right? So understanding kind of the facial muscles, where their origin is, where their insertion is, what their action is, all of those factors kind of play into what kind of aesthetic result you're going to deliver for that patient. And so, yes, I mean, anyone can be trained to do it, but to do it well, you have to have these other kind of components, and you have to have more of an understanding, right? Like I can show other, like, yeah, inject here, here, and here when they come with this complaint, but if you don't understand what's my endpoint of injection, what should it look like, right? What's the natural contour in this area? You're not going to get the best result, right?
Yeah,
From a
I've been
complication
pondering
standpoint,
about opening a preventive cardiology slash Sculptra practice. Yeah.
Humayun's going to start doing echoes and Sculptra.
That's the goal. But yeah, sorry, go
if you
ahead.
start doing that, you're going to stop doing echoes pretty soon.
Yeah, no kidding. After one clinic.
You're like, all right, no more
Hey,
echoes.
so I have a question, Jonik, about
Yeah.
Botox. Okay, like there's a lot of stuff, especially like, I think it's like very much like a marketing thing, but maybe I'm incorrect with Botox about that you've got to start Botox super young as a preventive thing and do it for life because if you start it when you see wrinkle lines, it's already too late. You got to do it to prevent it. Is that legitimate? Is that true? Or is that just a
That
ploy
that
to get people to serially inject for longer?
No, so I think so it's not true, but I'll explain kind of what the kind of concept is, right?
Yeah.
So first of all, when you kind of your lines or your wrinkles on your face, they come in kind of two fashions, right? One are called dynamic, so like it's when you're expressing yourself. So like if you smile really big and you get the lines on the side of your eyes, those are dynamic, right? But when you don't smile, you don't have them. So that's kind of the first, and then you have what are called static lines. And so as you age, some people will get the static lines. And so, there are people who are very expressive and they do that same expression over and over again. And so then those lines will slowly become static.
Okay.
Botox will fix, Botox will treat the dynamic lines, right? And they will soften the static lines, but they won't efface them. Okay, so that's kind of how Botox works.
Okay.
Now, this concept of preventive Botox, I kind of liken it to this analogy. If if you started dyeing your hair before you had any grays, no one would ever know you dye your hair, even when you get
Too
grays,
late for me,
right?
bro.
Yeah. So same thing, right? Preventive Botox, you start doing it when you don't really have wrinkles. I mean, then no one's gonna ever know. You just keep doing it, right? And you look like you've never aged, or you look like, oh, you're not doing anything. That makes sense.
Yeah,
So I
yeah,
think
yeah.
that's really the mechanism of preventive Botox. Now,
Okay.
um, there is, I think, at least from my experience, there's a side benefit of Botox that people, I think, don't always talk about, and that is actually it does improve your skin texture and quality. And I just so your skin looks smoother, even if you don't have a lot of wrinkles. Your skin looks smoother. So I mean, there is benefit of doing it, but no, there's preventive. Like I think it's more analogous to what I was saying about the hair coloring, in my mind at least.
Gotcha,
There's
gotcha.
no
Can,
there's
can you
no there's no physiologic basis of like, oh, if you do that, if you paralyze the muscle longer, you're gonna delay aging.
No, that makes sense. I mean, that's a good perspective. The way you explained it, that makes a lot of sense.
in terms of Botox and fillers, can you doing too much, can it be harmful for the skin and the facial muscles as well?
Yeah, that's a great question. And so Botox, I would say, is relatively safe. I mean, we haven't seen any kind of muscle atrophy or any of that of those kinds of things with repeated use, right? What we sometimes you may need a little bit more in terms of units to get the same effect as you've kind of used more. Rarely are we seeing people who become kind of resistant to the Botox, which means that you do it and either they don't get the same effect or the duration of effect is shorter. And in those cases, just switching brands or can alleviate that issue. So we haven't really seen what you might think in theory could be some of the issues with Botox. I think with Botox, or broadly speaking, neurotoxins in general, what the issues are is incorrect placement can lead to un you know event things you don't want to have happen, right? The most common would be you can get eyelid ptosis if you inject the forehead too low and it gets into your levators. Fortunately, there's eye drops to help kind of offset that, if you will, and then in three months it's going to wear off. And it always wears off, and so you kind of return to baseline
Now,
once
what
that
is this
happens.
idea of the filler staying within under your skin and kind of spreading
Yep.
around and making your face structure change?
Yeah, so fillers is very different, right? So filler, um, you know, we think that they all dissolve, and in certain areas, we now know that they really are almost permanent, right?
Like
There's actually
paraffin wax. Paraffin wax won't
yeah,
dissolve.
there was actually this great study done out of Canada, where they did under eye filler and they took MRIs of people, and like even 10 years later, they showed that there was some residual filler there, you know, and so that's one issue. Second issue is, like we talked about, the vascular occlusion. That's probably the most devastating complication, and that's what happens if you don't know the anatomy and you inject the filler into a blood vessel. You can get what's called an embolus, and that basically, because the facial vessels are all branches of your carotid, and so when you retrograde, have an embolus, it's going to go into your brain, give you a stroke, or occlude the optic artery and give you make you blind. And at the very least, it'll give you tissue loss. It'll give you local ischemia to an area. And so, again, pretty rare complication. Again, with the proper and knowledge of anatomy and technique, you can, I would say, avoid it. You should be able to avoid it almost all the time. Um, and but obviously the most devastating. And then the other parts of fillers is you can get some what are called nodules. So sometimes you get inflammatory nodules. Sometimes you get nodules. Those you get a low grade infection that creates a little nodule, and so those can be sometimes difficult to treat as well. So those are some of the issues. I think more and more people, I think, are kind of getting filler of what's being termed filler fatigue, and kind of like what you were saying, right? That because they don't fully dissolve, you're essentially stacking and building up filler, and so then it's starting to change what your face looks like. Because once it's just sitting there, it's not behaving it doesn't have the same properties as the actual filler, what it was designed for. If that makes sense, right?
Interesting. Yeah.
Let me ask you this: in terms of like gender differences, like what do you see in your practice on the cosmetic side, like men versus women? Guys coming in versus girls coming in, and like face wise, what are the different stuff that guys usually want done versus girls? What men and women want done?
Yeah, so that's a great. I think I mean, even historically, it's been mostly women, right? That's changing
Right.
a little bit. Obviously, still even today, it's mostly women that are coming in for procedures, but more guys are coming in. It's more accepted, which is good. Um, from a facial aesthetic standpoint, I would say the most common or the most popular things for men is kind of around the eyes, what we call periorbital rejuvenation. So upper eyelid blepharoplasty, lower eyelid blepharoplasty. oftentimes because, in general, men have their brow sits a little bit lower, and their frontal bone is a little bit more forward, and so they can look kind of tired and like heavy eyes a little more easily, you know, than a
Gotcha.
woman. And so I think that's what really that. And then the other thing is the neck, especially now that we're on, Zoom calls and stuff. People see this contour a lot, and so
Hmm.
both men and women will come in for that. But now men are coming in for kind of doing something about the with the turkey neck, or just that fullness in their neck. So I would say those are
Gotcha.
probably the most common or most
Do you
popular.
see a lot of hair loss stuff? Because I've been seeing things like PRP injections, and how much truth is that? How much evidence is there behind PRP injections into your hair follicles for hair growth and things like that?
I mean, so there is evidence for it. The
And
question
PRP,
in
just to clarify for everyone, is plasma-rich protein, right?
yeah,
Yeah,
Um,
platelet-rich plasma.
platelet
Yeah.
platelet plasma, yeah.
yeah, platelet
And
plasma.
so, they have like trials that show, clear benefit of PRP. The question always is it more beneficial than finasteride, right? Like, and so that is, I think, somewhat debatable. You have people who think PRP works great, and you have other people that say PRP doesn't really do anything. I think that there's obviously differences. I think if you take the PRP of a 20-year-old versus the PRP of an 80-year-old, there's got to be differences in terms of just what you're getting, right? And so that probably affects its efficacy as well. Um, I think hair is complicated in terms of for a few things. I think you got to have a multimodal approach to hair because um, you know there are different mechanisms or different things that trigger hair growth. And so I think having a multimodal approach is probably makes the most sense. And then, it's patience, right? You got to do it for a long time because the hair growth is such a slow process that you're not going to see a benefit for 6 to 9 months. And so, kind of getting someone to commit to doing something and waiting that long to see progress is kind of hard. Um, but yeah, I think there's definitely a lot of promising technologies. The most recent one is a FDA approved laser treatment that has 25% shows 25% increase in hair growth. After a series of treatments, which is about 4 to 5 treatments, which is pretty powerful and pretty exciting.
Right, that's just like a
Uh,
surface laser. Like you just expose it
yeah,
to the
it's
skin in the
it's
area to the laser, huh?
yeah, exactly. Yeah,
Wow.
it's
So,
yeah,
and I know
very
we're
cool.
getting quite a bit on time as well. So I did want to kind of ask your opinion on a couple of things. What do you think is the most overrated aesthetic procedure, and what is one of the most underrated aesthetic procedure in your view?
So I don't know if I would classify them as overrated or underrated because these are very personal decisions for everyone. And so, what bothers one person doesn't bother another person. Sometimes patients will come in and they'll say, "Oh yeah, my eyes really bother me." And you look at them and you're like, "Well, you should be worried about this, this, and this." But obviously, you don't tell them that. But so it's very individual, right? And so, I would reframe that question and say, "Well, what's the biggest bang for your buck?" Right? And so I think upper eyelid surgery, and then liposuction of this area, the chin or the neck. Um, and I say it's the biggest bang for your buck because it's relatively low downtime, pretty easy surgery under a local anesthetic, right? Um, Pretty reasonable cost, but the effect is really good. Like it makes a huge difference in your appearance, right? so, so I think those are two, at least on the face, those are two procedures that are, I think, kind of really good bang for your buck. Um, I think liposuction can be amazing for some people. It just depends on kind of, it's great for people who are actually in shape and have a little bit that they can't lose because you can just contour that, right? So I think liposuction is another one for at least for the body that like potentially could have a lot of, bang for your buck, if you will. A little more downtime, a little more involved, but in terms of effect, you get a pretty good effect. Um, but yeah, I wouldn't say anything's overrated. I think it just, kind of individual, the balance between how much it bothers you and are you willing to have the downtime, right?
Yeah.
Kind of that's the formula.
Yeah, and I guess I asked the question the wrong way, but I was kind of trying to tease out the trend versus something that's evidence backed or time backed. We see in cardiology, we're seeing a lot of different things, wellness and longevity, and a lot of things do not just have evidence behind it. We did a whole episode on peptides last month, and there's a lot of things it's hard to kind of endorse that right now because, hey,
Dude, Humayun
every
loves peptides. That's basically what it was.
huh? Yeah,
So,
there's a lot of things that it's hard to endorse that because there's not much evidence behind that yet. But people are going and seeking it, right? And it's become a trend, and a lot of people are selling it. What is something like that in plastic surgery that's become a trend? It's very popular. People are seeking it, but it's not. We're not sure if it's very effective or not.
I mean, I would say, at least in the plastic surgery world, it's all of the things you just mentioned. It's all the more on the wellness side, right? I'm kind of like you. I really like the wellness space. I think there's a lot of potential there. I do think that it's being oversold at this point. I actually went in December, went to the A4M, which is like the biggest anti-aging kind of conference, and I was a little disappointed because the claims they're making are bigger than the data, right? At this point, um, I would say I think that there is some promise, but telling someone you take this peptide and it's going to do all these amazing things to you is wrong because we don't have the evidence to back that. Telling them, hey, take this peptide, it may do these things for you, and it probably won't do anything bad to you. I think framing it that way is better, right?
Yeah.
Because I do think that some of these things do have efficacy, and we might not be able to measure it yet. We might not be able to measure it on a population level, right? Some of these things might be individual, right? So if Adil takes one peptide, he may feel nothing, and you take it and you feel great, and it's and I think that can be true. Um, but to just kind of get up get up there and be like, hey, yeah, this is going to like cure all your problems, I mean, that's wrong. So
Yeah,
I think the space is
there's a lot of big talk
there's a
from
lot of
these
big
guys on
talk.
the podium for sure. But I
Yeah.
mean, like, dude, I have so many patients that take peptides, and it's that number has grown in the last year and a half. And I mean, like, again and again and again, anecdotally, these patients swear by it. I mean, and they're so aware of their cycling the peptides, they know the dosing, they're injecting it appropriately, and like I haven't seen any direct negative effects of it. That doesn't
Correct.
mean that
I
I'm going to start prescribing it, but like I have been very pleasantly surprised.
Yeah. Yeah, I mean, this conversation we can keep going on, but we got to put an end to it at some point. But it was a lot of interesting stuff. I think I learned a lot. I hope the few people who watch us learn a lot. yeah.
Yeah, it's
So
always fun.
yeah, it's good,
No,
good
this was great,
conversation.
man. It was awesome to have you. I think
Yeah,
it was really
thanks.
cool hearing your perspective because your practice is so truthfully different than mine and Humayun's because that aesthetic cosmetic side, which I mean we focused a lot on that, is just very different. I think it's really cool.
The one thing I kind of wanted to go back to one of the things that Humayun said. Like your patient relationship in plastic surgery, I would say, especially on the aesthetic side, but even on the reconstructive side, because even reconstruction, like breast reconstruction, it's like a journey, right? You're gonna do oftentimes multiple surgeries on the patient. It's kind of
Yeah.
the long you're knowing them for a longer period of time. But even in the aesthetic space, it's a more intimate relationship, meaning that you really kind of know them a little bit more closely than like I would say insurance-based medicine sometimes feels more transactional. Like when I was a general surgeon, you came to me with a gallbladder problem, I took your gallbladder out, I saw you one time post-op, you were doing great, I never saw you again, done, right? That was very transactional. Here it's not so much so. And a lot of it is because, okay, let's say someone comes in for one surgery, you get them through that. Maybe they're coming to your med spa for services, so you still see them. Maybe then a couple years or later, they're like, oh, I want to lift now. So then you're coming back to you for surgery. Like it's this more longitudinal relationship, kind of akin to like a primary care where you would like, see them as they age, right?
Or
Um,
cardiology.
or cardiology. Yeah.
But
So,
that's a very interesting perspective, Jonik, because just from the outside perspective, thinking when you hear cash pay cosmetic, it almost forces you to think, oh, that must be transactional. It's like, okay, here's some money, fix my face.
correct. Right.
But it's actually like how you just described is the exact opposite of that. It's not that at
Yeah.
all.
That's
And
awesome.
also I think realize that, a lot of these patients have been thinking about doing these things for years before they actually make a move, right? So just them showing up in your office took a lot of inertia for them. People think, oh, it's just money, or no, it's not that. It's everything. It's the whole psychology of doing it. It's like I want something, and it takes you a while before you're gonna take that leap into doing it, right? So
It's a huge thing, and the
there's a
trust they put in you. I mean, that's very, it's a huge thing. I mean, they're trusting you with something that is so dear to them, like their
yeah.
appearance.
Yeah, and it's very emotionally charged for them, right? Like again, when you have a surgery that you need, like a gallbladder, or you fracture your finger or whatever, there's really no emotion there. Yeah, I mean, I need the surgery. I'm
Yeah, it's
hurting
just
or whatever,
necessary.
right? But this is more like, there's so many more emotions that go into it. Oh, this is going to make me more confident, make me feel better, whatever, psychologically. So, I think that's the part of plastic aesthetic surgery that, a lot of physicians don't know about or don't see, you know.
No
Yeah,
doubt, man.
I've
That's
been trying to
awesome.
Yeah.
find that inertia to come to your office soon. So,
Yeah, come.
yep. All right. Well,
Awesome. Well, thank you again, Jonik, for tuning in. This was
Yeah.
great. I had a
Yeah, yeah.
blast.
No,
all
thanks.
right,
Thanks for
man.
doing this. Thanks for
Thank you,
inviting
guys.
me.
Yeah.
Yeah,
We'll
yeah.
do it again.
All right, everybody. Yeah, we'll run it
All
back
right.
soon. Thanks for tuning in to Two Docs, One Mic.
See you next time.
Awesome.
See
All
y'all.
right. See you next time. Bye.